The third and final case is a little bit less complex than the earlier two, but this is a gentleman, 76-year-old man with a history of diabetes, had prior stroke, DVT, and was currently on anticoagulation. He had a chemical stress test in 2019, which showed some mild ischemia, if I remember correctly. But he presented to an outside hospital with some chest discomfort and was a little bit nauseated without vomiting. EKG showed some acute injury patterns in some of the leads. I won't bore you with the details of that. But nevertheless, he was seen by a cardiologist and taken to the cath lab emergently based on the symptoms and the EKG abnormalities. What happened there was the cath showed diffuse multivessel coronary disease. The cardiologist felt that he wasn't a candidate for PCI or stent placement, so he recommended urgent coronary bypass surgery. The family, they did contact the surgeon at another hospital that I don't go to, but the family reached out to me through my answering service, and they wanted to come to the hospital I work at. So after a series of phone calls and working through transfers, initially we weren't able to get him there. We were finally able to get him to our hospital. So when I saw him that night and the next morning, again, a 76-year-old man, multivessel CAD, and the question was, does he need CABG now? I talked to my surgical colleague. We both agreed to let him wait for, the better part of a week on a heparin drip. As a surgeon like to say, let him cool off, stabilize clinically and hemodynamically. We did get one of our interventional cardiologists to take a look at the films, and he felt that PCI or stent was not, patient not a candidate for this. He'd be better off for CABG. Unfortunately, the patient, he didn't want to wait around the hospital. He left against medical advice after trying to talk him into staying. So he left within the first 24 hours. However, he got home, was there for maybe 12 hours, decompensated even more, came back to the emergency room, blood pressure was low, he was seen by the surgeon and the interventional cardiologist, and both were saying he was too sick to operate on. So his hospital course, when he came in, he had a troponin level. Troponin is a molecule we measure to determine if there's injury to the heart muscle. So he had an elevated troponin at the other hospital. It was elevated when he came to our hospital. We started this detox somewhere between the 1st and the 2nd of June. That's why I highlighted both of these. But the troponin was coming down on its own because he was just, recovering from an MI. B-natriuretic peptide, he came in at 300, and we started hydrating him, and the like, it went up. B-natriuretic peptide is a molecule that's a sign of heart failure. Oftentimes the heart muscles are tense with fluid. You can release more BNP. People with heart failure tend to have a BNP that should be elevated because that's their normal physiology. So when he was at 304, he was probably dehydrated, and other labs showed the same. His creatinine was elevated early on. With more hydration, that improved throughout his hospital course. And again, his GFR was low. I think this is more hydration in addition to low cardiac output. With the detox, he was drinking raw smoothies. He was getting salads, some fruit, and his hydration picked up with that as well. We were able to wean some medications, not a lot. He had a high lactic acid level, which did come down some during the course. And his inflammation, the reason I show white count is when a white count comes from like mid-normal to high or high normal, that's a sign of increased inflammation. And this, although it came down, his inflammation did not go totally to normal, even upon discharge. And albumin drops as so if the white count goes up, inflammation goes up, albumin drops. So this is not because he's on a raw detox diet. This is because inflammation, albumin leaks. And liver congestion, which was high, it also subsided as the patient recovered. So in summary for this patient, the reason for his decompensation, this patient was not on a plant-based diet. I'd been seeing him for a number of years. He's kind of old, stubborn, cantankerous gentleman. He had advanced atherosclerotic disease, had a hypercoagulable state with prior DVT and PE, pretty stubborn and non-compliant. He had started on a nutritional detox. Being in the hospital at bed rest can help a lot of people, and I think that helped him. When he went home, he probably tried to move about, and it wasn't, good for him. And in fact, we did do some medication weaning, not a lot in him, but we were able to wean some of his medication. But I think the nutritional detox was the main trigger for his recovery, in addition to bed rest and partial medication weaning. So here's a patient with advanced coronary disease who was in the throes of a heart attack, but he was too sick to receive what's considered the best treatment for a heart attack in emergency cases, which would either be an emergency stent or emergency bypass surgery. He was only left for a nutritional detox. So how do we know that this is working? I mean, could this just be 3 patients, Dr. Montgomery, you're just presenting, who just happened to do well, and you just gave them some smoothies at the same time they would have done well without the smoothies? And I think you can make that argument. And that's why I think we need to look at some of the data that we've shown, we've had before. And we've looked at in our previous publications, what are some of the effects, anthropomorphic and hemodynamic effects of food? We looked at a series of patients, and this is in an outpatient setting, where we put on a defined plant-based diet, similar to the diet I've treated these patients with. And we look at things like, weight, BMI, systolic, diastolic blood pressure, medication weaning. And what we see, there's a busy slide, but at weight, at a baseline on average, the weight is 108 kilograms, goes down to 107. These are all statistically significant difference from week to week. So we see the weight, the BMI goes down. That's no surprise to you. We also see systolic and diastolic blood pressure go down, which also should not be a surprise. Heart rate also goes down. And we've seen this before over the years. And we do this at the same time we wean medications. This is an important slide because it shows that you can get favorable hemodynamic effects with just food alone, while at the same time removing medications. This is data from a series of patients with congestive heart failure. We see that the stroke volume, the amount of blood that the heart contracts with each beat, increases. That increases the circulation. We see the amount of thickening of the heart muscle, the LV mass. So the heart, which is enlarged, it regresses with just diet. We also see that the stroke volume, again, the amount, this is the ejection fraction, I'm sorry, the percentage of blood that's ejected, and the stroke volume, the amount of volume that's ejected with each contraction, all goes up. And the cardiac output, which is total summary of circulation, goes up. So we know that food has a positive effect on patients with heart failure. I've highlighted some of the anti-inflammatory and biochemical results. C-reactive protein is a molecule that we use to measure inflammation. At baseline to final, we see about a 30% reduction in inflammation in just 4 weeks, very statistically significant. IL-6, we talked about these cytokines is one particular one that we measure, 23% reduction. We've seen this before. Plaque-2, which is a metabolic mediator, behaves in some ways like a reactive oxygen species associated with inflammatory molecules as well, 16% reduction. Fibrinogen, acute phase reactant, increased fibrinogen can predispose to clotting, a reduction by almost 6%. And white count, as well as also other types of sub-white count molecules, reduced by 22%, all in 4 weeks. This is just with nutrition alone. Metabolic changes, hemoglobin A1C reduces, and you see CRP goes down, insulin level production goes down, triglyceride lipids. So there are positive biochemical effects that we've already shown using nutrition alone. So we know mechanistically these things are going on. And to what extent they're happening in these patients who are acutely ill, more future investigations are needed. So moving forward, as I kind of close out this talk, I want to talk about our global objective. The study of the future study we're planning, we're actually in the process of launching the study now. But we're going to look at the defined plant-based diet, and we're going to compare it to Mediterranean diet. We're going to look at the effects of these two diets on patients with known heart disease. But we're also going to look at not only the clinical effects, but in the very same patient, we're going to collect blood and look at the biochemistry of what's going on in these patients. At the same time, we're looking at the physiology and the clinical findings. We're going to randomize the study. They're going to have food provided by 2 nutrition centers. And we're going to try to correlate the clinical effects of the diets with the biochemical and molecular effects. The things we're going to measure are usual blood pressure, weight, echo, EKG stress test, cardiac monitoring. We're going to look for cardiac arrhythmias at baseline plus after. We're going to look at lipids, C-reactive proteins, a lot of biomarkers that we normally look at, as well as questionnaires. And we're going to look at biochemical assessment. So we're collaborating with the university where we're going to look at TNF alpha, IL-16, IL-1 beta, many of these cytokines that we talked about earlier, nitric oxide, polyphenols. We're also going to analyze the macro and micronutrients of the food they're eating. So we're going to look at the biochemistry of the patient, their blood, and we're going to look at the biochemistry of the food that they're eating. We're also going to look at other things such as monocyte, leukocyte isolation analyses, endothelial nitric oxide. We're going to look at gene expression of cell hypertrophy, and we're going to look at sarcoplasmic reticulum stress. So there are a lot of technical terms here, and I'm not trying to bore you to death, but what I want to do is give you insight to the fact that we're going to be looking at from the clinical aspects of what's happening to these patients, and at the very same time, what's happening at the cells. Rarely do you see a study. You see lots of studies where we'll put patients on a plant-based diet and the blood pressure gets better, the blood sugar goes better. Well, what's the mechanism? What's happening? And we're going to look at that. And this is a study that's rarely ever done in medicine. In fact, we looked in the medical literature, haven't seen any study where they looked at the biochemistry at the same time they looked at the clinical effects. Usually these biochemical details are done in animal studies, or they may be done in isolated human studies, but you're not looking at the clinical effects at the same time. So it's a really important study that we're looking at. And I think it's going to give us insight as to exactly what's happening with these patients. A quick word about the food. I won't belabor it. Picture's worth 1,000 words. This is an example of some of the food that people eat on a raw detox regimen. You have the nori rolls, you have the Hulk burger, beet burger, and that's a raw pizza with salads. We have dehydrated onion rings with a Hulk burger there. We use super greens in their smoothies and a blue-green algae also in their smoothies. This is a better than tuna sandwich. So this is just a snapshot of the types of foods they consume in this type of a regimen. So what are my final thoughts? Why do we do this? What's the purpose of all of this? First of all, the benefits of leading a healthy lifestyle, pretty much universally accepted. Diet and exercise, we know that. The benefits of a plant-based diet are generally universally accepted. I know that some people promote other diets, but plant foods are part of those diets. But I think plant foods, I think universally accept as healthy foods, and plant-based diet, the data I think is very strong that are superior to other diets that are non-plant-based. However, when you get to plant-based diet, how do you apply this, this whole lifestyle medicine in clinical medicine? A patient's sick, on 20 medication, a short of breath, or swollen. How do you supply it? So what foods should you consume in what circumstances? Some people say, no fruits, high fruits, low fruits, et cetera. Raw versus cooked versus uncooked. So, what are the answers? And then we're going to get into some of these things. We'll look at the biochemistry of what happens in the sickest patients first, and then we'll work our way back. From where should you get the foods? I mean, is a salad from a fast food restaurant as good as any other salad? How should food be prepared? Should it be microwave, steamed, dehydrated, fried, all the above? So there are a lot of questions in terms of how you apply nutritional lifestyle. And a lot of these questions need to be answered, and a lot of them needs to be answered in a clinical setting. So our vision is to develop a nutritional interventional process or processes with scientific validation that will contribute to a greater understanding in this area of the application of optimal nutritional lifestyle in the clinical setting.